got his baby.
Yeah.
He just got his baby.
Oh, yes. Yeah, brand new.
Brand new.
Good luck.
Not installed yet. In the process being installed.
Yeah.
Hello, Raymond.
How are you?
How are
Yes,
you? Fine
Raymond.
to see
All right,
you.
and you?
Raymond, where did you see Raymond? I did not see
Long time
Raymond.
no see.
Raymond is there.
Yeah. How do you?
Where's Raymond? I did not see Raymond.
He's there. He's very much. He's waving at you.
Oh,
Can you see me, Rosie?
hi, my dear doctor. It's
How are
been
you?
too long. When was the last time we saw one another?
I think it was in Egypt.
Yeah, I was in Egypt. And then
Yeah.
with David, we have the whole plan of visiting South Africa. And then the COVID-19. Yeah, the COVID-19
Going
stopped
into a
us.
third wave now.
Yeah, okay. So it's great to see you. Great to see you. So let's wait. Okay, we're not there. Okay, we still have 5 minutes to the meeting. Okay. So Dr. Hamid and Raymond. So today we have 6 African countries, doctors from 6 African countries online. Okay, so this is really quite exciting. Okay, so this is from Addis, from Dr. Klimash. Hi, Dr. Klimash.
Yes.
Yeah, looking forward to have you and your team join us. Let's wait another 4 or 5 minutes, okay, till we start. And also I'll have my team to check whether everyone is online. Oh, Samuel, I saw Samuel, okay, I saw Samuel. Clementa, okay, Clementina, I saw Clementina, Dr. Clementina Karuki online. Oh, actually, can Dr. Clementina Karuki, can you hear me? I saw your name. From Tanzania, I saw Dr. Clementina Karuki.
Hello.
Hello.
Good morning.
Good morning. Oh, yeah, it's your morning time. It's in China, it's the afternoon time.
Okay.
Yeah. We're going to just wait a few more minutes. Okay. Oh, Dr. Tatsura, okay. Hold on. Okay, let me revert back to my list.
We can see, but now we can see.
No, this is screen. But for them screen, they watch you like this and this screen. This is screen. They watch you by small screen and then the
How
big
to return back?
Stop sharing. Yeah.
That screen.
Just join the
And we practice.
yeah.
Okay. You're sure? Yes, it's not. It's possible to share.
Of course, it's better.
Okay. Let's give another 2 minutes or so. Okay. Okay. So let's wait another minute or so for the Zambia team to be get online. Then we're going to start. Okay. Dr. Hamid, you look sharp. Did you lose more weight?
Yes. You're smart, yeah.
Yeah, I can tell.
I'm trying, yeah.
Since,
I'm trying.
since last time I saw you in Dubai.
Yeah, I'm trying.
Yeah. Okay, I think now let's stick to the clock, okay? And first, okay, before we start, let me ask the non-speakers to turn your microphone to mute, okay? And when we open for discussion, then those who will speak will open the microphone. In this way, we'll not hear the background noise, okay? And so welcome everyone, okay, to this webinar. And it is my great pleasure to be the moderator of this webinar, okay? And my name is Rosie Xin. So I'm a professor at the University of Chongqing Medical University, and I'm also the managing director of the International Department of Chongqing HIFU Medical. Okay, so therefore, I'm here to welcome all of you to join this event. Okay, and before we start the program, okay, first I would pay thanks to, I think, thank two people who prompt us or precipitated this event. Actually, they are not doctors, they are diplomats, okay? And first is the diplomat from the ambassador from Zambia, okay, who Dr. Muzaza, who is also a surgeon by training. Okay, so he serves as the medical director. He's also served on the MOH, okay, for Zambia government. Okay, so in last September, he came with the ambassador from Zambia, pay his first visit to Chongqing HIFU, and with his medical training as a surgeon, he radically recognized the uniqueness of this non-invasive new technology, what we call the high-intensity focused ultrasound, non-invasive option, surgical option, okay? And who returned, okay, this week and spent this week with us, did intensive, did in-depth understanding and learning about this technology, both on the clinical side and also on the development, the history of this technology, and also visited the few clinical sites in China and received his step one clinical training, okay? And so Dr. Muzaza, because he has 3 roles in one person, okay? He brought us, actually he said he came to learn from us, but he met with my team, and I thank him for coming to us, and which let us know more learn from him than what he learned from us, which is about the Africa, the new Africa, the health system in Africa, and what this technology means, not only at the clinical level for the doctors and for the patients, but at the health economics level, at the social economics level, what this technology can do to meet the needs of African people and African patients. Okay, so I thank Dr. Muzaza for that. Okay, and another person, another diplomat I would like to thank is actually Ambassador Karuki. Okay, who actually is from a medical whose family is from a medical family background. Okay, so he came to visit Chongqing HIFU Medical a month ago, 2 months ago. Okay, and also with his background, growing up in a medical family. Okay, and he readily recognized what this technology meant for Africa. Okay, so since his return, I've been working with Ambassador Karuki closely, and to see in how can we bring the medical community together, okay, to get to know this technology. So Ambassador Karuki is on a field trip in Xinjiang, so he could not join us, okay. And owing to these two diplomats, actually brought to my attention, to the attention of Chongqing HIFU, that to bring this technology to serve the needs of the people in Africa, okay? And we need not only, we needed to understand the needs of Africa, and we need to have the African doctors from different countries, okay, to come together and to discuss whether this is a suitable technology for Africa. And if it is, how can we set up a system, a framework, okay, from medical education to the training, okay, and to the set up the service, okay. So in which way can we integrate this service into this technology into the current medical system in Africa, actually also hand over this technology to the clinicians, okay, to the medical professionals, medical specialists, for them to learn and to integrate into the practice, current practice, okay, and so that this can be, service can be delivered to the patients and to serve the needs of the patients, okay. So for this purpose, okay, we decided to, with the presence of Dr. Muzaza still with us on site at Chongqing HIFU, to call this webinar, okay. So on the webinar, we have 6 clinical teams from 6 countries in Africa, okay. 3 countries in Egypt, South Africa, and Nigeria, we have set up our clinical centers, okay? And so we would like the director from our HIFU center in these 3 countries to share with you how their experience about delivering this service and treatment to the African patients, okay? And what are the challenges they have, and what are the advantages in their views about this technology, okay? We also have the clinical team from Ajayi Hospital in Ethiopia, which we are in which is considering the HIFU project for their expansion of the hospital service, and for the new maternity and the children's hospital, okay? And then definitely we have the medical team from Zambia that Dr. Muzaza has assembled for today's webinar, and also, although in his absence, but Ambassador Karuki has also assembled group of medical specialists, especially in OB-GYN and the discipline, and who join us on today. Okay, so without the further delay, I think the program first, I think the first three speakers, okay, in the order of Dr. Raymond Setzen from South Africa, and followed by Professor Mohamed from our Cairo Center in Egypt, and then Dr. Ajayi from our Nigeria Center. So we'll follow this order. Let's invite them to first share their experience of deploying, of using this technology to serve the African patients. Okay, and our South African Center is set up in the public service hospital as a public service in the Barabara Hospital, largest teaching hospital in South Africa. Okay, and who is mainly doing the fibroid treatment in fibroids. And Professor Hamid's the center, Professor Hamid's a professor of Cairo University and is an interventional radiologist by training. So in our Cairo Center, we're not only, Dr. Hamid and his team are not only treating uterine fibroids, adenomyosis, but also expanded to other indications, benign or malignant. So this is for you for him to share with you this technology, the breadth of this technology and the indications it can serve, okay, it can treat. And then Dr. Ajayi, the director for Nigeria Center, which is the new kids on the block, okay. And Dr. Ajayi actually is a fertility specialist. He runs successfully the IVF centers, and we'll hear from him why he chose to set up a HIFU center and how he thinks this will help to improve the fertility for women who suffer from infertility due to larger fibroids. Okay, and so let's open today's webinar by inviting three speakers to share their experience first. So first, let's hear from Dr. Raymond. Dr. Raymond, I turn the floor to you.
Thank you.
And,
I'm just going
okay,
to
yeah.
open my slides. Okay, so good morning, good afternoon to everybody. I'd just like to thank the organizing committee for inviting me to speak at this fantastic webinar. I'm going to be talking about HIFU application in South Africa, and I'm going to be talking mainly about the management of fibroids. Just trying to see when my slides are not moving. It's not moving, just wait. I don't know why it's not moving. Can you hear me?
Yes, we can.
Yes, we heard you. Raymond.
I don't know why the slides are not moving. Can anyone give me some advice here?
You make a share screen?
Yeah,
Share screen?
it says I'm on share screen.
Yes.
Okay.
Let
Dr.
me just
Raymond,
try
maybe
again.
you can escape first. Escape the presentation.
Let me just try here now.
Click ESC.
It was working 2 minutes ago when we tested it.
Yes, that's right.
Let me just stop the share here. Let me try it again.
Yeah.
Oh, I don't know why it's not doing anything now.
Still not.
Click on the slide. Click on the slide.
Mm. So how?
Oh, okay, let me do it that way. Okay, sorry about that. All right, so I work at Chris Hani Baragwanath Academic Hospital, which is the largest hospital in South Africa, and also in Southern Hemisphere. And in fact, it's quoted in the Guinness Book of World Records as the third largest hospital in the world. We've got approximately 4,000 beds in the hospital. This hospital services the needs of Soweto, which is a black urban settlement bordering on Johannesburg, which is one of our major cities. And in Soweto, we've got a population of about 5 million people. So we service quite a big population. Just some pictures to show you what Soweto looks like. There's a lot of informal settlements. You can see the shacks with outside toilets, but there are also formal houses as well. So it's a combined settlement. My hospital it's a government hospital, which is affiliated to the University of Witwatersrand, which is one of our major universities in South Africa. We are the largest training hospital in South Africa. The vast majority of patients that we treat at our hospital are black patients. We were also the first HIFU center in Africa. We got a machine in late 2015. And all the patients, most of the patients that we treat get treatment free of charge. That's just a picture of the entrance to our hospital. It's a very busy hospital, as I'm sure most of the African hospitals are throughout Africa. You can see there's always large queues of patients waiting, backlogs for theater, backlogs for clinics, very busy hospital. When we look at the healthcare system in South Africa, it's divided between private and public sectors. The private sector caters only for about 15% of the population. So the state, the government, take care of about 85% of the population. So these are all government hospitals, which we service the lower income groups. As I said before, most of the treatment is free. And these hospitals are chronically underfunded, understaffed, and overloaded with patients. The total population in South Africa is about 58 million people. And around about 50% of that is made up of black females, 29 million black females in South Africa. So if you look at the fibroid profile, we know that there's the prevalence of uterine fibroids is 3 to 5 times more common in black women than in Asian or Caucasian women. So we have a huge problem with fibroids in South Africa. And the majority of our patients that we see in our gynae outpatients department are patients who are presenting with fibroids and the related complications. And I'm sure this applies to most African countries. If we look at the profile of our patients, as I said before, they're mostly all black females. We have a big problem with obesity. We've got a high HIV positivity. Our patients are late presenters. And I'll go through each of these in more detail. We see a lot of young patients, infertile patients, and patients with extreme symptoms. In a study that was done in 2017, they found that by the age of 20, there's probably half of the South African women are overweight. And by the age of 45, this goes up to about 82%. So this impacts on traditional treatment of fibroids, operating on these patients. It's always a lot more difficult on obese patients with a lot more complications, wound sepsis, etc. Also, we have about a 25% positivity with HIV in our reproductive age patients. And again, this creates problems in theater. There's always a chance that one of the doctors might get cut or a needle stick injury with transmission of HIV. So it is a problem when we're operating on these very big patients who are HIV positive. Another problem that we see in our African patients in South Africa is they present late. They always seek alternative forms of treatment before they come to us, whether they go to traditional healers, herbalists, or whatever. A lot of these patients are infertile. and they desire pregnancy. So when they see a mass growing in their abdomen, they suspect that they might be pregnant, and then they don't come forward to be assessed. Patients also, it's a common problem with us. They don't come for routine checks. They only come in for a checkup when they've got some chronic problem. There's also quite a marked fear of hospitals and a fear of surgery. So because of all these factors, the patients present very late. And as a result, we see these big fibroid uteruses, multiple big fibroid uteruses. If you look at the MRIs, you can see multiple fibroids. So it's a problem. Another issue we have in our South African patients is infertility. Now, we've got a lot of different tribal groups. We've got at least 9 different tribal groups, and there's many varied traditions and cultural beliefs. And one of these is that in order for a lady to get married, she needs to be fertile. So there's a very strong desire for fertility. And another issue is that the greater the number of children in a family, the higher the social status of that family. So these patients want to preserve the uteruses. They don't want to have surgery and have hysterectomies. So they're very worried about going in for any kind of surgery. Also with socioeconomic issues, our patients, there's a very high unemployment rate. It's over 27%. So patients are very nervous about coming in for traditional surgery, which is going to take them off from work for at least 6 weeks. They're worried that, that when they get back, their job might not be there anymore. And it's also very difficult for them to get sick leave. So that's another issue why they are not keen to have traditional surgical management. So if we look at the burden of traditional treatment, which what I'm talking about here mainly is a laparotomy whereby either a myomectomy or a hysterectomy has been performed. If we look at the burden on the healthcare system of this kind of treatment, these patients need admissions to the hospital, and they're going to be in the hospital for quite a long time. On average, it's about 5 to 6 days. So there's a marked burden cost-wise on the state, having all these patients admitted, staying in the hospital for 5 to 6 days. Also, the wards are very overcrowded. They fill the wards. When we do these big operations, particularly the myomectomies, even with some of the hysterectomies, there's usually quite a marked blood loss. So we use quite a lot of blood products. And as we know, blood products are scarce. I think throughout the world, they're scarce and they're quite costly. So that adds another big expense to the hospital. And also we have a surgical backlog at any one time of around about 450 patients. So these are patients who are requiring myomectomy or hysterectomy. And these patients are going to wait from the time they book, they're going to wait at least probably about 8 months before they get to surgery. So in that time, the fibroids are going to grow bigger. They're going to have more symptoms. A lot of them will require blood transfusions. So it's a problem. So now if we look at the development of fibroid treatment over the years, as we mentioned in the beginning, it was the traditional form of management was a laparotomy whereby either a myomectomy or a hysterectomy was done. And this is pretty invasive kind of management. Can have problems, bowel injuries, bladder injuries, ureteric injuries. Patients develop marked adhesions post-surgery. So it's quite invasive. And then through the years, we've come up with sort of more minimally invasive kind of procedures. But now we've come up with something that's completely non-invasive, and that's HIFU. This is what our machine at Baragwanath Hospital looks like. We're not going to go into the details of how HIFU works. One of the other speakers is going to talk about that. Just to show you that the HIFU, this HIFU with the A.M.Nthele, that's the name of the company that developed this technology and who's developed this machine that we see down below here. And as you can see, their motto, treatment should minimize harm to patients. So we should be getting away from traditional kind of medicine where we're doing this invasive surgery. And our machine is the model JC200. So what are the healthcare benefits of HIFU? Why should we be using HIFU? Well, we are now doing these cases as day cases. So the patients come in the morning, they have the procedure done, they go home in the afternoon. So we don't have any hospital admissions anymore. So there's marked decreased costs to the state. They don't have these admissions. And also the wards are more manageable. Normally we would have at least half the ward will be filled up with surgical patients having non-urgent surgeries. So the wards are far more manageable. There's no general anesthetic given, so it frees up our theaters for more urgent cases. And because the treatment is completely non-invasive, there's no blood loss. So we don't have the necessity for blood transfusions anymore. So again, we're preserving our scarce commodities. And again, it's saving us quite a lot of money on the blood transfusions. As I mentioned earlier with the HIV transmission, there's no contact with the patient at all. It's completely non-invasive. So there's no risk of HIV transmission. So it's far safer for the whole medical team. And the actual procedure is very safe, and there's very low risk of complications such as bowel, bladder, ureteric injuries, which would then require further surgeries, further time in hospital, etc., etc. And what are the benefits to the patient of HIFU? How do they benefit from it? Well, again, as we mentioned, it's a day case, so they don't have to be admitted. So they get back home on the same day. There's no general anesthetic, so their recovery is much quicker. And also they return to work within a few days. So in terms of job security, they don't have to worry about losing their jobs. They're going to probably be away from work for 1 or 2 days as opposed to, say, 6 weeks. And because the treatment is non-invasive, the uterus is spared. If you were doing a myomectomy, there's a good chance that you would need to proceed to an emergency hysterectomy because there's uncontrolled hemorrhage, or by the time you've removed all the fibroids, you can't close the uterus. In this kind of procedure, we don't have to worry about that. The uterus is spared. The myometrium is not damaged. Because it's such targeted, precise treatment, the myometrium, the surrounding the fibroids, is not damaged at all. So these patients, if they fall pregnant, they can have a normal vaginal delivery. They don't have to have a cesarean. Also, because it's non-invasive and there's no abdominal wound, the patients return to normal activities, exercise very quickly. Within a few days, they could be back to their normal routines. And the other big factor is obviously there's no adhesions. Now, when we do myomectomies, we know that there's always big adhesions that develop post myomectomy. With this treatment, there's no adhesions at all. Also, there's no ionizing radiation with HIFU. So this treatment can be repeated. If we have patients who've got multiple fibroids and we can't treat them all at one sitting, we can treat them again thereafter without any problem. There's no danger from it. And because it's such localized treatment and no radiation, the ovaries are completely safe. There's no damage to the ovaries. So you don't have to worry, like with uterine artery embolization, you might get some damage to the ovaries. And also from a cosmetic point of view, women don't like big scars on the abdomen. So with this treatment, the abdomen is spared. So if you have a look at this picture here, you can see what the abdomen looks like after laparotomy, after laparoscopy, and after HIFU. There's absolutely no marks on the abdomen at all. If you just have a quick look at the recovery time following the different procedures, you can see that with the ultrasound guided HIFU, within 1 to 2 days, the patients are back to normal. They might need a little bit of analgesia, but otherwise they're fine. Whereas if they had a hysterectomy or a myomectomy, they'd be off for at least 4 to 6 weeks. So that's quite an important thing in terms of their recovery. I just want to quickly go through some of the South African results. And this is mostly on fibroids. We don't see too much in the way of adenomyosis. So I'm going to be talking here mainly about fibroids. To date, we've treated just under 500 patients. And you can see the age ranging from as young as 18 all the way up to 45 years of age. That's another thing that I forgot to mention earlier, is we're seeing a lot of younger patients. Now, routinely, patients with fibroids present around about the age of 35 or so. In our patients at Baragwanath, we're seeing patients as young as 18 who are presenting with quite large fibroids and quite severe symptoms. And also you can see there that the weight varies from between 43 kilograms all the way up to 115 kilograms. Abdominal wall thickness, we shouldn't go above 6 centimeters in terms of treating the patients. So there we around about 33 to 64 millimeters in thickness. Now we've treated a total of about almost 1,200 fibroids, of which 327 of the cases were multiple fibroids and 158 single fibroids. The rest is not important. The patients who we've treated, most of them, as you can see, present with dysmenorrhea and menorrhagia. Those are the two big problems. And then we see a lot of patients with anemia, HBs below 10. Infertility is another big problem. And then bulk symptoms like constipation, frequency of urination. Now, during the treatment, obviously this is done under conscious sedation. So the patients do experience some symptoms, which are of short duration. They get low abdominal pain like dysmenorrhea, which is normal. They can get some pain in the buttocks. They can get a hot sensation on the skin, and they can get some pain down in the legs. In terms of major adverse events, in the just under 500 patients that we've treated, the only thing that we've experienced so far are 2 cases of first-degree skin burns, which resolved spontaneously within a couple of weeks without any surgical intervention. We've had no bowel injuries, no bladder injuries, and no permanent nerve injuries. Now, of 500 cases that were going for surgery with major myomectomies and hysterectomies, we would have had a lot more serious side effects at surgery. If we look at what we do with our patients is before we start treatment and post-treatment, we work out a quality of life score. And then we do that. So if you look at the before the treatment, you can see they had a low score of about just over 35, indicating that their quality of life was quite poor due to their symptoms. And then at 1 month, then we check them again at 3, 6, 12, and 24 months. And you can see how the quality of life scores have increased. And by 2 years, it's almost up to 75. So there's a marked improvement in quality of life of our patients. If you look at the symptom severity score, the same thing. If you look before the treatment, the score is just below 60, which indicates quite marked symptoms. And then as we go 1 month, 3 months, 6, 12, up to 24, you can see how there's a marked improvement of the symptoms. So for our patients, there's a marked improvement in quality of life and the symptom severity, and they're very happy with it. If you look at the shrinkage rate, it's at 1 month already, it's about 31%, going all the way up to at 12 months, on average, about 73% shrinkage rate. In terms of fertility successes, we've had 16 cases. 8 patients are currently pregnant at the moment. We've had 1 4-kilogram vaginal delivery, and we've had 7 term cesarean deliveries. One of the problems here with our patients is once they fall pregnant, a lot of the time we lose them to follow up. They don't come back to us. They just continue with their gynecologists, where it's in private practice or at one of the clinics or one of the government hospitals. So our figures, we are sure are higher than that, but of the ones we know, we've got 16. This is just a sort of baby gallery of some of the patients that have conceived following HIFU. Just quickly show you some of the cases we've done. Here we've got a 40-year-old lady before the HIFU. There's the fibroid there. And this is 1.5 months after the treatment. And we can already see that there's a shrinkage rate of about 27%. And what we actually look at here is the ablation rate, is to see how much of the fibroid we've killed off. And you can see the black area indicates that there's no uptake of contrast, and that shows you that almost 98% of that fibroid has been ablated. So we expect a lot more shrinkage to occur. Here's another case. This one is before the treatment. This is 4 months afterwards, and there's already shrinkage rate of about 63%. There's another case of this. This is just 23 days after treatment, and we can see already there's probably just under 10% shrinkage rate. There's another case. So, in conclusion, I would just like to say that from our perspective, HIFU has assisted in transforming women's healthcare in South Africa. It's made a huge difference to our patients. It's made a huge difference to the actual healthcare system. It's a safe and effective alternative treatment for uterine fibroids in our Black patients. From the patient's perspective, the important thing for them is that they're retaining their uterus and therefore they're retaining their fertility. There's a quicker recovery. They're back to work much quicker. They can have normal vaginal deliveries. And from the health system perspective, because of there's no more admissions, the costs are reduced, the decrease in blood requirements, and there's a quicker access to treatment, which is also very important. As I mentioned earlier, patients are waiting up to eight months to a year to get a surgical procedure, whereas with the HIFU, we are getting them done within probably a month. So from that point of view, it's working very well. So at the moment, as Prof. Rosie was saying earlier on, we've got 3 machines in Africa: Egypt, Nigeria, and South Africa. And hopefully we're going to get a lot more machines, because this definitely is a vitally important part of the treatment of fibroids, especially in our public hospital in the African setup. Thank you.
Thank you, Raymond, for the wonderful lecture, okay, and which is also a great summary of the South African experience, okay. So let's leave all the questions to the end of the discussion, okay. So now let's move on to Professor Mohamed, who is going to share with us the Cairo experience with
Good morning. You hear me now?
Yes.
It's better? Good morning, everyone. I am happy to share my experience with my friend from Africa, our motherland. And first of all, I want to thank my dear friend in China to arrange this meeting, which is very important. The screen is okay, Jenny?
Yes, Dr. Mohamed, we can see your screen.
Okay. My story is starting since 2012. And I am different as a HIFU believer, because I am searching for the technology, not the company or anyone offered it to me. I searched for the technology, and I found that the Chongqing University and the Chongqing technology is the best one. So I traveled to China many times since 2011 till we can bring this machine by the assistance, a great assistant from Professor Wang, Professor Zhang, and of course, dear Rosie, as a great friend. And is our center Our center is opened at 2017. It's a private center with my partners, Dr. Rania, Dr. Fauzi, and Dr. Nagla. I am the head of this team. They are all friends. And we have a GC machine. And this is our experience about the HIFU. We treated 506 patients. 308 is complaining from uterine myoma and adenomyosis. About 200 cases complaining from malignant tumor like liver, pancreatic tumors, liposarcoma, aggressive fibromatosis, and benign breast lesions. And we also treated bone metastasis. We haven't ultrasound contrast in Egypt. Of course, I learned HIFU in Chongqing and Suning under observation of Professor Zhang, and of course we have many friends from African countries visit our center, and we are honored to arrange the first training company outside China in our center. This is Professor Shen and all our friends, and of course Raymond, my dear friend, and Dr. Wang, Dr. Ruzi came to our university, Cairo University, and my medical hospital. Of course, it's a different story from my opinion. As I am interventional oncologist and working on interventional techniques, I am searching for a new modality can help the people more and more to treat difficult tumors we can't treat regularly. Like cancer pancreas, I treated cancer pancreas with nano knife. It's very aggressive and it's a difficult technique. As bone tumors, we treated by even with surgical drilling and put needles to ablate the tumors. So it's a long story to find a new technology helping the people, and it's valid for many types of tumors. To understand what is the importance of HIFU, we must know what is the level of research and proof we are now in the HIFU. In the HIFU, now we have an FDA-approved treatment like brain essential tremors, neuropathic pains, Parkinson's disease, back pain, and osteoid osteoma. All of this are approved outside USA. But in USA now, they're treating essential tremor and Parkinson's with HIFU. Also, the oncological application of HIFU is progressing day by day. Now in Europe and all over the world, they can treat the cancer in bone, prostate, breast, especially in Japan. Now they are doing very well with cancer breast in HIFU, cancer kidney, cancer liver, and we have a good experience for liver cancer in Egypt. We treated more than 100 patients now with cancer liver. Pancreatic cancer, we treated almost around 100 cases. Soft tissue tumors, we treated osteosarcoma, liposarcoma, bone metastasis with very good results. So we also, another proof for the validity of the HIFU, this is a statistics from the Foundation of Ultrasound, revealed that the total registered number of the patient treated with HIFU is more than 250,000 patients. And I think there is many patients unregistered at these statistics. And we have uterine fibroid, it's almost half of the patients, prostate cancer, liver cancer, and this is a large number. At the end of the story, now we have FDA approved technology, we have FDA approved application, we have CE and Korean FDA and the Chinese FDA approved techniques like cancer liver, like adenomyosis, like cancer pancreas, and we have now this also the graph of the number of the center all over the world. You can see there is a great improvement in the number of the centers treating HIFU. And the astonishing thing, most of these centers located at Europe, and this is very important. So another issue, as you know, the reflection of the importance of any technology, how is the progress of manufacturing of this technology? You can see we have ultrasound guided HIFU, and which type I prefer, MR guided HIFU, MR guided and ultrasound guided HIFU, camera guided HIFU, and we have now about 28 manufactured all over the world going to increase the number of HIFU. And this is very important. You can see this is the practical application of HIFU all over the world. And you can see this is the Europe, most of the center located at the Europe. And of course at Asia, at China, India, South Korea, and we have Middle East also. You can see our machine ultrasound guided HIFU Chongqing is the best all over the world, as it's valid for many peoples, and also all the people can train on it easily. And this is very important because I have an experience with MR guided HIFU and ultrasound guided HIFU. And from my point of view, I went to many countries to receive and trained for an HIFU treatment, because when I wanted to bring this technology to Egypt, I decided to use this technology, which ultrasound guided, and it's more safe and more feasible. So how the HIFU improve the treatment for the cancer patient, not only for the benign treatment. The HIFU is proved to have many actions to destroy the tumor. First of all, tissue destruction by thermal abrasion, histotripsy, and microvascular disruption. Second technique, and which is very important in oncology, it's immunomodulation. By thermal effect of the HIFU, there is tumor cell disruption and the augmentation of immunotherapy drugs, and this is proved by many papers and research. And at the end, the drug delivery, which cause improvement of focal delivery of therapeutic agent to treat tumors like cancer pancreas, and even in brain metastasis. Now, MR guided HIFU making a pore in the membrane of the cell membrane of the brain, allowing the chemotherapy to cross blood-brain barrier to reach the chemotherapy for brain metastasis. So the HIFU is break even in the medical field. So again, we have a mechanical destruction, we have a drug delivery augmentation, we have improvement of the chemotherapy. Again, tissue disruption, immunomodulation, improvement of drug delivery, and even secondary radiation effect. Before you working with the HIFU, you must know very well the anatomy, how to use a proper position for the patient to get the most benefit from the HIFU. You must know very well the surgical approach for every tumor, what is the surgical approach for osteosarcoma, what is the surgical approach for liver, what is the surgical approach for the fibroid, to know very well which plan and which line you treat. Of course, you must be oriented by some of physics, like a direction of power and what is the reflected power produced from the HIFU. And at the end, you must know how to use the least power. Another rule, if the tumor distance, the tumor size, the tumor vascularity is less, you will get a better benefit from the HIFU and you will treat it in much shorter time. A brief, this is the theory of HIFU. We concentrate a power at the point far away from the transducer by 12 to 16 centimeter. And you have a coagulative necrosis effect as you increase the temperature to reach 100. The machine is very easy to use. You can make a semi-automated plan for the treatment of the HIFU, for the treatment of the tumor. And at the end, the patient is stable, and you move the machine to make line by line, slice by slice, and at the end, you get a volume from tumor ablation. You can see, this is the idea. Of course, the most popular is ultrasound guided. We have also MR guided HIFU. In most of the patient, like liver, like pancreas, like fibroid, the patient are put in prone position over the tank, and you have some accessories to compress the bowel, like this. And the HIFU machine, ultrasound guided HIFU machine, is very nice as you have many accessories to move the probe, and at the end you can see very well the tumors. As you see, this is a pancreatic tumor. In the regular work, as a radiologist and as a practitioner for ultrasound, it's difficult to identify the pancreatic tumor very nice. But with HIFU machine, with water media, with a compression, you can identify the pancreatic tumor very well, and so you can safely ablate it. The average time of most of the procedures is about 2 hours, like cancer liver, cancer pancreas, cancer uterine fibroid. This is the total time of operation. And the actual time of operation usually from the actual time of sonication as the patient treated with HIFU is about half an hour to 1 hour or less. So first of all, I will talk about the most difficult tumor growing with least treating procedure all over the world. I'll talk about the pancreatic adenocarcinoma. It's one of the most aggressive cancer. The overall survival is 2 years. Always there is comorbidity. The patient is old, and the vascular inclusion of the tumor. Most of the patients are inoperable, and most of the patients are terminal. You can see this is an anatomical guidelines around cancer, around the head of the pancreas. You can see there is a lot of vessels, a lot of biliary tree. It's very difficult as a surgical technique, and usually the patient discovered late. Also, we haven't a lot of chemotherapy for this patient. Only we have 4 FDA approved agents for cancer pancreas. And the funds for the cancer pancreas is very low all over the world. We have only a nano knife, and this is very important. Many people talking about HIFU, ultrasound guided HIFU, as where is the certificate for FDA? It's not proof, and etc. etc. This is not right. The FDA approved a HIFU technology as a treatment for many, as a technology for treatment for human medical diseases. And this is a very good situation regarding the safety and regarding the efficacy of the treatment. This is like FDA approved the nano knife, but in contrast to the nano knife, we have only very few patients treated all over the world with this technology. So the HIFU in pancreas is rapidly providing rapid pain relief also, and high safety, and it's non-invasive. This is a biggest, I think, meta-analytical study published from Netherlands, talking about the application of cancer pancreas in HIFU. And you can see the ultrasound guided HIFU is more solid and providing better results. And also it's improved so much the treatment of pain in the patient. And our group in Egypt published 2 papers, one in AUM and and one in Vienna, talking about the effect of HIFU on the tumor and on pain. This is our paper published in USA talking about the color Doppler assisted technique to delineate the boundary of the tumor. As you can see, this is the tumor. We can see the celiac trunk very well. We can hit the tumor very well. And this male is 59 years old, complaining from large 6 centimeter locally advanced pancreatic cancer. You can see this is a locally advanced pancreatic cancer. And this is the side of the tumor. We treat this patient with 2 sessions. And you can see after 9 months, the PET scan is free, completely free. And by MRI, you hardly identify the tumor. There is almost, the tumor is vanished. And of course, the PET scan showing no activity. And this is very important. Also, this lady complaining from large tumor, receiving chemotherapy with progressive course, we decide to treat it with HIFU. And you can see this is a tumor, ablated tumor, and this is the vessel, not injured, and this is the metallic stent. Another one with very small uncinate process tumor. The patient refused to surgery, and this is the tumor. We're treating this patient, and the patient is still living for 2 years and even refused to receive chemotherapy. And you can see, this is the uncinate process now. It's clear. You can't even identify the site of the previous tumor. Another issue in Egypt is the hepatic tumors. And the hepatic tumor is very, very common in Egypt because we have a virus C. And this is my study in the MD about radiofrequency for hepatic tumor. And the question is public question in Egypt. Does the HIFU really work in the liver? Because the liver is very difficult. We have reps. It's a very deep organ. And I'll just show you a proof from Hong Kong. This is the group of Hong Kong treating liver with HIFU, and they show us result from HIFU, and even it's equal for result. I'll show you some of our cases for liver, like the pancreatic cases. This is a small metastatic tumor related to the portal vein for this young lady complaining from metastatic colorectal cancer. This is the tumor, and we can delineate it very well. And this is just after the treatment. We make an ultrasound for the patient. You can see the hyperechogenic tumor, and this only for 60 minutes. And the MRI now show the complete ablation of the tumor. There is no enhancement, and the portal vein is okay and intact. Another one, another metastatic tumor in the left loop. As you can see, we can treat right and left loop. The left loop, and this is during the technique, and this is after. You can see we can ablate all of the tumor without any activity. Another lesion at this area from also colorectal cancer metastasis, we can see this is a wedge-shaped ablation with very efficient results. This is another case with cholangiocarcinoma, and all of us know the cholangiocarcinoma is very difficult to treat it. And this guy came to us from country outside Egypt. With central cholangiocarcinoma, we apply a HIFU for 2 hours, and this is the result. We ablate all the tumor, and now, till now, this guy is 2 years ago, contact us in Egypt and sending his greeting every now and then, and he's still alive. The fibroid in Egypt is similar to all of Africa. Most of the patients are virgin. They are the most are complaining symptoms is bleeding, and some of them complaining from pressure symptoms. Usually it's multiple. We have now 7 HIFU babies. I'll show you some of our experience regarding different side of the HIFU. This is a common classical large one with very good ablative. This during the HIFU. This is MRI after the HIFU. As another one complaining from abnormal uterine bleeding. This is a posterior. The first one is anterior wall. The second one is the posterior wall. We can anterior and posterior wall. The third one is very large with heterogeneous picture in MRI, and this is very important. Don't worry about the heterogeneity. Not always you need to hypovascular or hypointense. No, the heterogeneous fibroid tumor is okay. It will respond very well to the HIFU treatment. Don't worry about the multiple fibroid. You can treat all these fibroid at one session, but take care. You must know what is the maximum volume you treat. You can treat cervical fibroid, large cervical fibroid. Don't worry, you can treat it. This is a large cervical fibroid, and this is the result after the HIFU. You can, maybe you can got a very good result at this patient, very large tumor. And you can see after treatment, it's ablated very well. And even the slough and the uterus gain, it's normal shape. Even if you have a partial response like this lady, we ablated it, but we only have about 60% ablation. Don't worry, maybe it worked. Just follow up the patient, the bleeding is stopped, and it's get well and get well again. Again, as an oncology interventionist, I wanted to push the boundaries of the use of HIFU. You can see the guided HIFU now, it's very, very famous for treatment of soft tissue tumors in pediatric age group. And this is very important. And we have Professor Sharma from India, it's working in USA with very good experience. And of course, in China, we have a great professor like Dr. Chen and Dr. Zhang. They treating these tumors very, very, very nice. So we starting to do this in Egypt. Starting to expand our boundaries with HIFU. This baby with large neck tumor treated many times with sclerotherapy and with not improvement so well. We make a very low power for treating this solid component of this tumor, and you can see this is before and this is after. It's of course not completely disappear, but even this girl can extrude their tongue outside their mouth before she can't. And this is good. This is a step forward. This guy from Iraq is complaining from aggressive fibromatosis and operated many times before, came to us, and I decided to make an angiography before it to see the vascularity, and I did it myself and make an embolization with particles and then make an ablation on 2 sessions for this fibroid. And you can see we can even ablate more than 60% of the tumor in 1 session. Again, this young lady with aneurysmal bone cysts, you can see this is the tumor, and we can make a HIFU for the synovium of the wall of the aneurysmal bone cyst. So, HIFU will take a very good role in treatment of the cancer, especially with increasing the effect of the immunotherapy. And I think this will be the surgery of the future. Thank you very much, and thank you for attendance.
Thank you, Professor Hamid, okay, for the wonderful lecture. And I think, through Professor Hamid's talk, those who attended this webinar, who are new to get to know this technology will know that the application of this technology, although the most mature area is OB-GYN, but it's not limited to OB-GYN. Actually, it's just the beginning. With this technology opens a whole new area of medicine. Okay? So as the Professor Hamid says, you know, it is he's been pushing the boundaries to see how this technology can be expanded to treat other indications. Okay. However, you know, once we set this up as a service, usually we started with OB-GYN. Because why? Because fibroids is the learning curve. Okay, learning to treat the fibroids is learning curve. Once you've been trained well there, then you can broaden that training experience and move to combine with your clinical experience. Okay, so thank you, Dr. Hamid. Now let's move to Dr. Ajayi. Okay, the newest kids on the block. Okay, and just to remind the speakers, okay, the next two speakers, because we have the clinical team who join us. It's the morning in Africa, so many of you may have. Let's keep the time tight, okay, so that we can leave some time for discussion. Okay, so Dr. Ajayi.
Can you see my screen?
Yes.
Fantastic. Yes, so thank you very much, Rosie and the organizers for inviting me to talk, especially talking after the two people that have spoken now, who have shared their experience on HIFU in Africa. So I'm just going to look at what we can do in Nigeria and in Africa about HIFU. So I'm talking about understanding the HIFU technology, but I'm not going to talk so much about the technicalities. I want to talk about the clinical impact of gynecology in Africa, of HIFU on gynecology in Africa, with emphasis on uterine fibroids, and just mention a little bit about adenomyosis, and then also with drawing a parallel to my first love, which is infertility treatment. Yes, first and foremost, warmest wishes from Lagos. These masquerades are known to be associated with Lagos, and so I bring good tidings from Lagos and from the Fibroid Care Center at Nordica. Uterine fibroids are the most common benign pelvic tumors in premenopausal women, and in Africa, the approximate lifetime risk is about 70 to 80%. There are many management options for fibroid-related symptoms, which include expectant management, like the medical treatment, and then you have the non-excisional, non-surgical procedures like uterine artery embolization, and of course, our beloved HIFU, and the old-fashioned surgery, myomectomy and hysterectomy. Of course, this can be either to cut or to do laparoscopic surgery or hysteroscopy. We'll try to talk about a little bit about, mention a few of those things. Well, we know that fibroids are the commonest benign tumors in women, with the preponderance among Africans, like my friend Raymond alluded to. I'm going to try to look at the works that have been done in Nigeria and try to see how we can marry it with, because my thinking is that we have a big tool on our hands that can help us to fill some of the service gaps that we have in Africa, okay? So it's like something that's been hidden from us for a very long time, and I think now that we find it, it's a good way to see how we can use it. When we talk, there was a survey in one of the teaching hospitals in South Nigeria, which reported that fibroid surgery accounts for about 7.1%, that fibroids account for about 7.1% of all gynecological admissions and 21% of major gynecological surgeries. The interesting thing, just like was seen in South Africa is that majority of these cases were between 30 to 39. We're going to see why some of these things are important as we go on. And the commonest mode of presentation was heavy menstrual bleeding, lower abdominal mass, and dysmenorrhea. Another study from southwestern Nigeria showed that the common presenting complaints were menstrual irregularities, abdominal swelling, and infertility. And also measured the average uterine size at presentation, and the majority of these women had multiple fibroids. This has been one of the things that had been the nightmare sometimes about us and HIFU, thinking, okay, multiple fibroids, can HIFU really take care of it? And I'm so glad that Professor Mohamed has spoken about this. But I'm going to dwell a little bit more about this infertility. There's always been this debate about what is the relationship between fibroids and fertility. So one of the best papers I could see on this was released earlier this year by Edgardo Somigliano from Milan. And he looked at the relationship between fibroids and natural fertility. It was a systemic review and meta-analysis. Well, the conclusion was that, yes, the epidemiological studies suggest, but they do not demonstrate that fibroids may interfere with natural fertility. That is, there's an association, but why this is so, we don't get it. Given the high prevalence of these lesions in women seeking pregnancy, further evidence is urgently needed. That was the conclusion from Edgardo and his team. But I think one of the things we're going to talk about at the end of this presentation might just point out to some of those things that probably is hidden that we need to uncover. Now, I try to look at the effects of fibroids on IVF. Okay, because this fertility, to many people, they think that the problem of Africa is that we need to control childbirth. But they are missing the point that a lot of Africans also cannot have children. And so fertility treatment is also something that is gaining so much ground in Africa. And so we have to look at what is the effects of fibroids on IVF outcome. There's always been a debate, but there's a lack of gold standard to see which fibroids needs to be removed. Because just like we don't know how fibroids and infertility, it's like the chicken and the egg. We don't know which one came before which. But there was a study that we did in my center here in Lagos, and we also leaned heavily on the work of Elizabeth Pratt from the US, who did a big meta-analysis of fibroids and IVF and concluded that the position of the fibroids, it's very important, whether it should come out or you can debate whether it can stay or not. And we agree that with her that all submucous fibroids should be removed. But one of the most pragmatic publications on this, it's one by Sandogan and Sandogan. One of them is in Turkey, the other one is in the UK, and they had this paper together. And they pointed out the importance of location, that is, whether it's submucous, whether it's intramural, whether it's subserous. Just like the paper of Pritz also said, and they concluded that all submucous fibroids of any size must be removed, whilst intramural greater than 5 cm can be considered for removal. Subserous can be left alone, except if it's going to disturb your egg retrieval, then you really don't need to chase after it, because also the paper from Pritz has shown that even when you remove this, it has no effect on your treatment. In fact, talking about intramural fibroids, after removal, there's not been any evidence to show that there's improvement in pregnancy rate. And that's one of the things I think might just give a window to HIFU in this place. Because, you know, just like we pointed out earlier on by Raymond, that there's destruction of the musculature of the uterus when you do myomectomy. And HIFU tends to spare the muscles. So this might just be what we have been waiting for. I hope these are things that I think we need to look at and do studies on as time goes on, especially for us in Africa where fibroids, it's very, very popular and common. When we look at the treatment of fibroids in Nigeria, myomectomy is the commoner surgery for fibroid treatment in Nigeria. There was a study from northern part of Nigeria which showed that as much as 75.6% of surgeries from fibroids was myomectomy. And in southeastern Nigeria, it was as high as 90.3% of surgeries for fibroids. This is not surprising because we have seen that majority of the people who have fibroids and are willing to do something about it, at the back of their mind is their fertility in Africa. And just like when Raymond was talking, he said about 53% of their patients actually had presented us with infertility. There was another report from southeastern Nigeria where they were looking at what are the complications that come from myomectomy, this very common surgery that is done in Nigeria. And this was very scary that they had about 86% transfusion rate post-myomectomy. And about 25% of the surgeries were complicated by severe hemorrhage, and post-myomectomy anemia was about 24%, and there was actually a severe mortality from severe hemorrhage. These are pointing out, maybe this might look a little bit scary because it was from a teaching hospital, so you probably have some people who have been trained to become gynecologists doing this, but this is the stark reality of what we're confronting from fibroids in this part of the world. But there was also another study recently which showed that postoperative complications is as high as 25% after myomectomy and as high as 29.3% after abdominal myomectomy. So we can see that this surgery, as common as it is not without complications. And therefore, there must be a way to look for something that might just be a little bit milder than what we're doing now. In another retrospective study from one of the teaching hospitals very near Lagos here showed that the commonest complication was still intraoperative hemorrhage requiring blood transfusion. So it's like myomectomy, it's a blood draining surgery. And the estimated mean blood loss was about 630 mils of blood. And they saw that the higher, the bigger the fibroids, the more significant the blood loss and the need for transfusion. Great. But apart from this, the complications that can come from the surgery, immediate post-op complications, hemorrhage and so on, there is also, from our own point of view of fertility, there is a problem that is also associated with myomectomy, which is the fact that you can have a lot of intrauterine additions, and which might in fact impact on the fertility of these patients. And we looked at that also in this in my clinic. We looked at about 900 patients who had hysteroscopy between 2005 and 2014, and we saw that open myomectomy was one of the highest on the list of surgeries that can lead to intrauterine fibroids and intrauterine additions, which of course complicates the fertility of these young women. So we also looked at what about laparoscopic myomectomy. I mean, we thought, okay, if we go from something very aggressive to something less aggressive, let's look at what laparoscopic myomectomy. And we reviewed the first 31 patients that we did here in my center as well. And all these are published papers. And we saw that about 23% of them actually had postoperative complications. Hemorrhagic complications are amounted for only 6.4%. Hematoma formation 3.2%, excessive hemorrhage, which led to open laparotomy, 3.2%. And overall mean blood loss was about 399 mils. And 9.7, only 3 of the patients required blood transfusion with a mean hospital stay of about 2.77 days after laparoscopic myomectomy. So we can see from all this that there is a need for something, a game changer. And I think this is where HIFU comes in. And we can, though, yes, we have heard from Raymond, we've heard from Professor Ahmed. Also, we can also look at some other people who have done some things in other crimes. And so the paper that was released from Hong Kong recently was also very heartwarming, where they shared their first 1 year experience in HIFU at the Hong Kong Center, where they treated about 147 patients, 85 of them were fibroids, and 51 adenomyosis. And that is one thing that we are probably missing in Africa. We are under-diagnosing adenomyosis. And I'll just probably at the end of this talk just mention briefly about that. And we see that these patients were successfully treated as day case procedures in Hong Kong. And the mild postoperative complications such as skin burn, back pain, and temporary sciatic nerve impairment were the only things that were recorded. Of course, the Addis study, which was done in China, which included 20 studies, also showed the overall success rate of HIFU in treating fibroids and other conditions. Well, I'm not going to talk about South Africa again because Raymond has dwelt extensively with that, and because also Rosie warned us about time, so I'm just going to try to conclude in the next 2-3 minutes. So my conclusion is that when we look at the fact that the patients in Africa tend to present late with fibroids, and the variant in Africa is probably more aggressive in Africans. So they may be larger and more in number at presentation. But we have seen from the experience of the two gentlemen that HIFU is effective, safe, and has less complications than surgical management. Of course, Raymond told us about the advantages, which include the fact that you don't need general anesthesia, which in this COVID era is actually a big plus. No blood transfusion. And then the HIFU machine does not need too many disposables. So majority of the things are things that you can use and reuse again, which is very ideal for a continent like ours. But what are the things that we should look at? What are the things that are likely to come up from this? Well, one of the things is I so much love this opportunity that we are rubbing minds in Africa, because we need a lot of collaboration. We need a lot of hand-holding. I see this technology as something that will help us a lot and is appropriate for us in this part of the world, and of course in every other part of the world. But and we see people like Professor Ahmed trying to push the boundaries and the application to other things. One thing that we probably also need to, but I've seen that also presented in somewhere in Spain, is that we might need over time to be able to continue to combine HIFU with endoscopy. For example, for submucous fibroids, you might need to do an hysteroscopy to remove the submucous fibroids. Because we've said that most of our fibroids there are many. And therefore, so it's not unusual to have submucous with intramural and probably even subserosal in the same patient. So you might need to have a combination of forces in order to treat this. Yes, but I must also talk a little bit about adenomyosis. We see even from the presentation of Raymond that he said they were not treating adenomyosis. But I guess adenomyosis is currently underdiagnosed in Nigeria and Africa. But I stumbled on a paper from somewhere in Nigeria where they reviewed over 5 years the hysterectomy samples that were sent for histology. And they saw 232 samples, 81 of these had adenomyosis. That's an incidence of about 34.9. So it means we're living with adenomyosis, but we're probably not making the diagnosis. And when we look at publications now are showing that adenomyosis affect women's fertility. So one of the things that might be responsible for the association of infertility and fibroids might be this undiagnosed adenomyosis, which we probably just need to pay more attention to in future. I think at this point, I'd just like to thank you for listening. It's been so interesting for me to be here. And let me thank you for the HIFU team for allowing your guys to come to us in Lagos, because as we speak now, they are currently installing a machine in Lagos, and we hope to be able to start using them. So by the next presentation, we should be talking about our own experience with HIFU. Thank you so very much.
Oh, thank you, Dr. Ajayi, for your wonderful presentation. I think Dr. Ajayi, as a fertility specialist, okay, has outlined from a different, from another angle, why from the fertility perspective, call for a less invasive technology, so that whether it's a natural pregnancy or assisted pregnancy can be performed, okay, can be achieved, okay. So, and so Dr. Jay, I'm happy to report that, okay, this year's international academic efforts will be focused on one question, is that how can HIFU technology help to improve the infertility in women suffer from uterine fibroids and adenomyosis. And if because the reason why we raise the question instead of with a period is that although for the clinical observation cohorts, we have internationally over 2,000 HIFU babies from our user centers, okay? So from the clinical observations is pointing to the improvement of fertility after the treatment. Actually, indeed, these babies were named for HIFU baby because the mothers gave this name because they could not, they have infertility problem due to the fibroids. And after receiving the HIFU treatment, they realized of their dreams to become a mother. So they named these babies HIFU babies, okay? Nevertheless, we lack the clinical evidence on how exactly this procedure affects fertility, whether it means to improve the fertility, and by the criteria, in which criteria we say it helps to improve the uterine environment and helps the fertility, okay? And this will require the collaboration of fertility specialists, which has already have a set of criteria there to examine the different phase of fertility, from like such as for IVF, from the implantation to the whole course of pregnancy to the delivery, okay? And to look at what are the effects of HIFU treatment on the process of fertility, okay? And another thing is that we don't know whether the clinical protocols we are giving right now, okay, whether they are optimized for patients with a desire for fertility. Means, can we treat less to preserve the uterine environment so that the patients can reduce their preparation time after the treatment, or with the existing the power the intensity we gave. Although on the imaging from the MRI ultrasound, we don't see damages to the myometrium, but do we know at the molecular level that will indeed actually is too strong, okay, for the entire endometrium, okay? So therefore, we also need research. We also need fertility clinics, fertility specialists together to optimize this procedure and to know exactly how to introduce this technology to serve the needs of patients who have a fertility in their mind, okay? So, but I'm also happy to say that because in China, we treat a large number of patients, and the total number treated using Chongqing HIFU technology worldwide with fibroid patients is over 170,000 patients. Okay, from these patients, we have about 2,000 HIFU babies, okay? We can say that the course of now, with the existing protocol, with women who have a desire for to become pregnant, either natural pregnancy or assisted pregnancy can be prepared after 3 months after HIFU procedure. Okay, so this has already significantly reduced from either myomectomy or open surgery. Okay, so without further delay, I would invite Dr. Klimash from Ajayi Hospital, who is and give us a brief introduction about the hospital, because this is we have been working with the Ajayi Hospital to introduce this technology. I think this will be the center will be put up in their mother and children's hospital. Okay, so Dr. Klimash, thank you. And
Thank you.
For the time is restrained, please keep your talk as short as you could manage, okay? Because of the time constraint. Thank you. Yeah.
Yeah, thank you. It's my pleasure to join this conference, and my report not about the scientific research, neither about the clinical cases. My goal is to report about Addis Ababa Silk Road General Hospital capabilities. But as far as I'm concerned, the owner of the hospital here, Dr. Wang, he is going to start HIFU therapy for local patients. Already we discussed about that with him. So Addis Ababa Silk Road General Hospital has was founded in 2017, located in Ethiopia, and has capabilities of 90 beds. We have emergency care ICU, 2 ICU units, one for COVID patient and one not for non-COVID patient. 3 operation room, outpatient department for COVID and non-COVID patient, and diagnostic unit. And more than 150 doctors, nurses, midwives, and auxiliary staff are employed in the hospital. We have 128 slices CT scan, 1.5 Tesla MRI scan, lab unit, and modern ultrasound diagnostic machines. So 1.5 Tesla machine provide high resolution visualization of a brain, spinal cord, and peripheral nerve system, and also ideal for abdominal and chest MRI when the patient can keep his breathing. 128 slices CT scan provides human body visualization within a couple minutes. With such, for some patients, it's very crucial, especially for comatose patients with multiple traumatic damage. As soon as traumatic damage can be detected, all needful surgeries can be undertook in a very short time window. And for some cases, it's a life-saving procedure to have a 128 slices CT scan. There is a neurosurgical microscope, Mitaka, in operation room, which provide high-quality optics and engineering for cranial, spine, and multidisciplinary microsurgery. I think it's the only one microscope of such microscope in Addis Ababa. CM in operation room provides operative navigation for greater safety and accuracy during spinal fusion surgery and orthopedic surgery. Addis Ababa Silk Road General Hospital is under patronage of World Federation of Neurological Surgeons and supported by free medical services from Chinese Medical Doctor Association. MRI, 1.5 Tesla capacity, 128 slices CT scan, ultrasound diagnostic machine, CM navigation system, and neurosurgical microscope in operation room, combined with support of World Federation Neurosurgical colleagues, make almost all neurosurgical operation to be performed in Addis Ababa Silk Road General Hospital. We have a laminar flow operation room. It's till the time being, the Royal of Anesthesiologists recommends that all joint replacement surgery will be carried out in the laminar flow operation room. So only orthopedic surgeon would like to have such laminar flow in operation room. Our orthopedic surgeon performs all kinds of upper and lower extremities, bones, fracture stabilization, arthroscopy, total hip and knee endoprosthesis. The ophthalmic department is fully equipped with diagnostic armamentarium for population screening at the purpose of early diagnostic of glaucoma and retinopathies. This ophthalmic surgical microscope assistant highly qualified surgical care for a patient without anterior segment pathology is available at the hospital. Standard otolaryngological surgical intervention with endoscope assistant are conducted in a hospital also. We have 4K ultra high definition endoscope provides a great advance in terms of visualization and spatial resolution. High resolution visualization of operation field provides a very detailed view of all anatomical structures and pathologies, allowing to improve safety and efficacy of abdominal surgery, gynecology, and urology. So the surgical establishment of our hospital offers a smorgasbord of urgent and treatments. I would like to emphasize there is opportunity for laparoscopic surgery for pregnant women up to 24 weeks of gestation who have abdominal emergency conditions. Our surgeons have such experience and equipment. So this is the view of a standard ward and VIP ward in hospital. For the time being, we have we start to treat suspected and confirmed COVID-19 patient hospitalization from March 29, 2019. All medical staff have been trained by World Federation representatives and Chinese military medical team who cope with SARS-CoV-2 infection. According to demands of local health institute and World Federation, World Health Organization, our hospital was reconstructed to meet all needful criteria for COVID-19 patient treatment. A negative pressure air ventilation system in the hospital and strict separation of COVID confirmed, suspected, and non-COVID patients are mandatory for infection control. PPE equipment included all needful protective for our staff. Also, we have a considerable and vital for adequate hospital functioning donation from China Chamber of Commerce, such as 20 invasive mechanical ventilator, 10 CPAPs, 10 high flow ventilator machine. So I have to mention that this Ababa Silk Road General Hospital is under patronage of World Federation of Neurological Surgeons in cooperation with service from Chinese Medical Doctor Association Voluntary Group. We have direct telecommunication with Beijing Xuanwu Hospital in China. And I strongly believe that having the latest innovation and techniques in diagnostic and treatment of almost all kinds of surgical conditions except cardiosurgery, having support from international multidisciplinary professional group, where Addis Ababa Silk Road General Hospital can serve as a national referral center for few institutions in Eastern Africa can match. And thank you for your attention.
Thank you, Dr. Klimash, for sharing with us this this brand new hospital. Okay, this for us, okay, represents the high quality, the demand for high quality healthcare in Africa. Okay, and so we're looking forward to work with the hospital management team and Dr. Wang and yourself, and to bring this to set up this technology as we envisioned, okay, not only for the medical service, but also serve as an anchor for the training, okay, down the road, okay, and also as a center of excellence, okay. So we're looking forward to the conclusion of this project, which now is delayed by the COVID-19 situation in Ethiopia, okay, which is the more urgent thing to do, okay. So thank you very much. Thank you. Okay, so now.
Prof, your mic is off. Professor Rosie, we can't get.
Okay, so thank you, Dr. Klimash, okay. And I think you just showed us an example of the high quality hospitals, which the high-end new hospital facilities, okay, and which shows us the demand for higher healthcare delivery in Africa, okay, and we're looking forward to work with the hospital management team and yourself to conclude the HIFU project, which is currently delayed by the emergent COVID-19 situation in Ethiopia right now, okay, and to also the vision we have for this hospital, for the HIFU center in this hospital, is to build this as a center of excellence. Also link to leverage the clinical team capability to deliver, to also do a clinical training, okay, in the area. Okay, so thank you very much. Okay, now let's welcome Dr. Muzaza, who spent a week here with us, okay, and to hear what he can, he will share from the perspective of a doctor, as a surgeon, but more importantly, as a government officer who served on the MOH and who also had been instrumental in the development of the healthcare system in Zambia, and from the clinical from the medical education to the National Health Insurance Program. Okay, so Dr. Muzaza. And also invite you to give a brief introduction to the medical teams that you brought with us, okay, if they are still online. And Dr. Muzaza.
Thank you very much, Professor, for this opportunity. At least we have heard from experts from South Africa, Egypt, Nigeria, and we have had an introduction to the hospital in Addis. They have made my work much easier. But before I proceed from presentation as a diplomat, let me introduce the team from Zambia. Team Zambia, if you can switch on your cameras just for the purpose of introduction, unless you have got the challenges. I'll introduce those that have recognized. I've seen our very senior teacher, the one who has taught almost everyone who is present here, Dr. Giseria Mukumba. You are welcome, my teacher. I've seen Dr. Shuma, a senior consultant in the Women and Newborn Hospital and the immediate past head of obstetrics in the main teaching hospital in Zambia. Professor, we have two directors here. We have a director in charge of women's health. I can only see part of his face, Dr. Angel Mwiche. You can wave at us. There is also the director responsible for clinical care and in charge of equipment, Dr. Sakanya. Please wave at the team.
Welcome.
I noticed a consultant there, Dr. Goshon Kasanda. You are very much welcome. And the last time I was here in September, when you offered that you'd want to train one obstetrician, the young obstetrician who was identified, Dr. Raymond Sivanda. You are welcome, Dr. Sivanda. Let me be quick to mention that this should have been done much earlier. We were supposed to have had this talk probably last year in December, and we would have loved to have had Dr. Sivanda trained here. Not only did HIFU offer a training for him, but the Chongqing Chamber of Commerce also agreed to support some of his costs. And it was him we were waiting to come and introduce the technology to Zambia. But unfortunately, COVID-19 has not been our best ally. So the plan has not changed. He will still have to be trained and then go into an in-depth discussion with Team Zambia. Professor, allow me to recognize the Tanzanian team and the Kenyan team who are in the similar booth as Zambia. My presentation is based on the fact that we were not aware of this technology until I visited the Chongqing on a different course altogether. That was in the fight against COVID-19, because that's where the PPEs were actually found. But when we passed through HIFU and saw the technology, I immediately realized that the Zambian team needs to know about it so that the people of Zambia could benefit from it. As you may know, when you are hungry, what comes into your mind is the food or the delicious food that you know. You won't think of a very delicious food that you have never heard of, that you have never seen before. So this is the situation for Zambia. We didn't know about this non-invasive technology. So I mean, there was no need for us to start looking for it and so on. And this webinar, specifically for Zambia, it was meant to introduce this new technology. But the professor has been kind enough to bring in people who have already implemented it in Africa. Those are the 3 countries that have presented, and it has made my work easy. I was going to go to the extent of trying to explain how high intensity focused ultrasound works, but that has been well done. South Africa has elaborated some of the indications, the benefits. So I will speak from the diplomatic and management point of view. We were waiting for COVID-19 to finish, but you see, we thought in the new normal, we have the virtual platform. So we said, let's introduce it now. Let the Zambians know about it. And as the presentations are going through, I'm sure there's a lot that is going through your mind. You have the clients already in your mind. We know the challenges that we have had as a country. I was sharing with the team at HIFU here that we mostly do open surgery, and that is myomectomy. And if it's difficult to remove it, we would rather remove the uterus. I mentioned that the theaters are shared with the other cases. So the treatment of fibroids has to compete with the other urgent cases. I've mentioned the issue of the use of blood. And when I heard the Nigerian presentation, I saw that up to about 86% of the people who have undergone myomectomy have had to have a transfusion. And about 25% had severe hemorrhage as a complication. I mean, that's not new, that's something that we also have in Zambia. And we know that blood is a very difficult commodity to find. The time I saved in MOH is one of the biggest cries that we had when it came to postponing of cases. And priority was given to urgent cases. So during my 5 days at HIFU, I appreciated the principles of HIFU, the simulation, and I observed clinical cases being treated. And I saw not only the application at the HIFU hospital, but also in a public hospital. We have looked at the pros and cons, the durability of the equipment, and I interacted with the professor who conceived the idea, a very interesting professor, who conceived the idea of HIFU and is now implementing it. He's not very old, even though quite elderly. And when I saw Dr. Mukumba as our teacher, and I had HIFU in mind, I said, Dr. Mukumba, we can extend your practicing career using HIFU for probably another 10 to 20 years. There's some music. Switch off your mic. Okay, thank you. From the South African presentation, you've seen that there are so many things that you get rid of in the process of treating fibroids. You no longer need to compete for theater space. You do not need to have all the surgical consumables that are associated with an open or indeed laparoscopic surgery. And when I was having an observation here, I was with the one who was operating, enjoying his tea while he's operating on the patient and even chatting with the patient. As you heard that we don't need the entire theater complement of team. We need minimum resources. And I think that's what he meant when he said the cost is actually lower. And he went to great lengths to explain the benefit from the patient's point of view, the benefit from the clinician point of view, and further from the management point of view. As somebody who is managing a hospital, I was expecting to have some head of institution from Zambia, but I think we are well represented. I will not go into the finer details of the benefits, but I will go to the gist of the issue. We have been doing open surgery. The younger generation of surgeons are quite excited with minimal invasive surgery, but it's not widespread. And we know that it doesn't solve some of the issues that we have had. Now we have an opportunity of actually skipping minimal invasive and going straight to non-invasive for the suitable cases. I like the Egyptian presentation because it looked at the other perspective, more on the application in the malignant side. Oh, I'm seeing another name here. There's Dr. Kampa here. Dr. Kampa, professor, is actually in charge of the cervical cancer program in Zambia. And I specifically invited him to be part of this, even though we will not discuss the management of cervical cancer. We will do it as a separate discussion altogether. For now, allow me to concentrate on the HIFU for the management of fibroids. But at the back of our minds, let's understand that it can be applied to many other solid tumors. Why we made this presentation? We would want the local team to review the process. I will share the materials through Dr. Stevanda so that you look at it, look at our situation, look at the profile of our patients, who would benefit from it. I think on the first issue, it has been well highlighted. But what from the patient's point of view? How would we implement it if we were to have it? can we have it in a public setting? Do we need to take it to the private setting? But first, I needed it to be introduced. I wanted to create hunger for the new technology. And I think it would be prudent for the team at HIFU to share the materials. And in the SMS section, I've received a number of requests for the presentations that have been given so that you could study on your own. I'm a diplomat, and I can talk and talk, but I thought as people who are listening, you have some questions, there are some specific things that you want to understand. I will curtail my talk. I've got a whole page, but it's not really necessary because of the 3 presentations that we have had. So I will end here for now and allow Professor to continue moderating so that we give chance to people who would want to ask questions.
Thank you, Dr. Muzaza. Okay. And so now I think I would also like to invite probably Dr. Clementina Karuki. If Dr. I'm not sure you're still there because if any of you leave because of clinical care, I fully understand. Okay, just welcome the Tanzania team, doctor team, because Ambassador Karuki is not here to introduce. Okay, so Dr. Clementina Karuki, are you there? Are you still in the audience? If you are, can you give us a brief introduction about the clinical team who are at the webinar? So probably Dr. Karuki is already no longer on the webinar. Okay, so it brought to my attention that actually because we put this notice, the meeting notice, webinar notice on the Facebook. So actually we have doctors more than just from these 6 countries, okay, who attended this webinar. So welcome you all. For those who you still stayed on, okay. And now let's open leave the rest of the room, the time for a discussion, okay. Let's do about, let's say we can have another 20 or 30 minutes or so discussion, okay. So I will so any speakers, any doctors who attend the seminar, that webinar, if you have a question, please open your microphone and to speak. And for the rest, we'll keep our microphone down. Then, depending on the questions, I might direct the question to the relevant participants. Okay, so that's how we're going to work. Okay, so now the floor is open to questions. So for those of you who have questions, you can just open your microphone and speak.
Dear Rosie, I want to ask a question for my colleagues Raymond and Ajayi. Please,
yeah.
Can I? Of course, I want to ask you. You now have an HIFU machine. Raymond, you have an experience about this. Why you didn't expand the application of the HIFU to invite a team from prevention radiologists or oncologists to expand the application? You can treat cancer pancreas, you can treat soft tissue tumors, and already you have a machine, and this is a great opportunity. And of course, you are now have an experience, especially Raymond, and you have a lot of friends can help you to start this work. What is your opinion about this, Raymond?
Yeah, look, when we initially got the machine, we did talk to the interventional radiologists, and I must say at that stage, they weren't really interested in partaking in using the HIFU machine. Also, I don't know with our particular machine, what other tumors you can treat. I'm not quite sure what other tumors can be treated with the JC200.
Yes, you can. You can, by GC200, you can treat all the abdominal tumors and even some of the musculoskeletal tumors, because you can treat this in Oxford. They use the same machine and they have treating different pathologies like sarcoma, HCC, pancreas. Of course, you have now a leader doctor and you have a good experience and you have a good number of patients. And of course, you can get the support from all the people you know all over the world. But this is, you have an opportunity. And Dr. Ajayi also, Nigeria is a very civilized country, and you have a good doctors, and even you can expand the opportunity to treat some another disease. And this is a very good, you can see in Egypt, we are just a private center, but well equipped, but we can introduce a lot of application if we have this way of thinking. This is my question. I don't know, Rosie, you can share your opinion with us about this.
Thank you, Dr. Hamid. I think I will have two comments. First, you're absolutely right. Okay, once the service is set up, means through the OB-GYN treating the fibers, because it's also the learning curve. Okay, so once the technology is being brought to an institution, okay, then I think a multidisciplinary approach should be applied, can be applied to include other specialists to learn, depending on the clinical needs of that particular institution, okay? And so on the oncology side, definitely pancreatic cancer, liver cancer, and the bone cancer, okay, it's the application of this technology towards the management of, especially the palliative care side, is mature. Actually, indeed, you know, I've been talking with Dr. Muzaza about starting clinical studies on small liver cancers. So this, yes, definitely, this is this service is not limited to OB-GYN. Okay, so and actually, if you look at our international centers, whether it's private or it's a public, in the public hospitals, it's set up as most of them are set up starting from the OB-GYN, then expanded to oncology. Okay, so this, my second comment is that in order for this technology to benefit not only the OB-GYN patients, but also also include the cancer patients, okay, and to expand it as a multidisciplinary program, okay, which requires the leadership vision, okay, to support the program, okay, beyond the one department, especially under the public hospitals, okay. I think more important is that, which I think what brought us together is important, is that we need to have a framework. Now we have some individual projects going on in Africa, okay, but we need a unified efforts, okay, and in Africa and in each country, starting from setting up the center of excellence, but then at the same time, we need to work on to build the education program, the clinical training program, so that the service can be expanded in the controlled way, so the doctors will be well trained in the stepwise way, and to ensure the safety and the quality and the delivery of this service. So that's my comment.
I want to add something. Of course, we put our center under your help. For any of our colleagues in Africa, you are all invited to see our center, to get cases with us, to attend, to learn with help of Chongqing. Of course, they are our teachers. And I think Raymond's did a lot of good cases, with very good repetition. I think Professor Ajayi will do this maybe better than us, but at the end, we must collaborate together, all of us, visit each centers. We can help a lot of patients and introduce this technology. I want
Yes.
to apologize. I must leave now because this is prior time. Sorry for this. I want to thank all of you and apologize again for leaving. Thank you very much. I'm very sorry.
Thank you, Dr. Hamid. Thank you, Dr. Hamid.
Thank you.
Yeah, you know, so now
You're muted.
let's take a question from the doctors who attend the seminar. Dr. Cassandra, if you can open your microphone and you can ask the question. Dr. Cassandra.
Thank you very much. I'm Dr. Cassandra from Zambia, and thank you for this presentation. It has highlighted a very important treatment opportunity for fibroids and the other tumors, abdominal tumors. And when we look at Zambia itself, all the treatment that are the indications or the treatment modalities that were discussed are actually needed in Zambia. We have patients with fibroids, we have patients with pancreatic tumors and the other problems. Now, my question is, what is the cost of setting up Alpha, particularly in low-resource countries like Zambia, in terms of setting up the system? And secondly, for Dr. Raymond and Professor Mohamed, who made these presentations and who are actually doing the HIFU as a form of treatment modalities, what's the average cost for the patient who are actually accessing this treatment modality? Thank you.
Dr. Raymond, do you want Raymond, do you want to take the question on the cost? Because I think
well, I can't really comment on the cost because we're a government hospital, and as I mentioned, the patients basically get the treatment for free. So I'm not sure, and we don't have there's no HIFU in private practice, so I'm not sure what the costing would be. I think overseas, I think places like Singapore, I think it works out at about $5,000. I don't know, Rosie, I don't know if that's correct or not.
I think Professor Hamid just left. Okay, so I will answer this question. Okay, so this really depends on the setup of the service. Okay, if it is set up in the public hospitals, just such as in the case of Raymond in South Africa, if they just decided the service is being put for free, and it'll be put for free. Okay, so I'll talk about the price range in our private centers. Okay, because this when it's introduced into a new country, a new region, usually it's covered by the commercial insurance first, or patient pay out of pocket. Okay, so it is interesting. Okay, it's from our center. We have about 60 centers across the global, okay, international centers. I would say about 60% of them are private centers. Okay, so if you look at how much women will pay from out of their pocket, okay, or to save their uterus, okay, despite where, so it looks like the average price they would be able to pay or out of their pocket is between $2,500 US to $6,000 US, completely out of pocket. Okay, and then in terms of how much the insurance will pay to cover, depending on the region. So in Hong Kong, this is set up as the first center is the high-end center. So if you look at the insurance will pay up to $10,000 for the procedure, okay? And in Singapore, it's around the $5,000-6,000, okay? And if you look at South Korea, where we have 20 private centers, almost exclusively focused on uterine fibroids, okay? These are small clinics, HIFU clinics, okay? And over there, the average charge for one procedure of HIFU is the total cost, okay, total cost, not just the procedure alone, is around the $4,000 to $5,000. So this is about the price range, okay? In terms of how much will it cost to set up the service, okay? Chongqing HIFU does not sell the machine alone. So what we're providing is a total medical service, which includes the modality at your choice. So it's between the JC or JC200, okay, which is the bigger version and the smaller version, depending on the space you have and what you want to do, okay? And the second is that we'll include a comprehensive post-cell maintenance program, okay, which makes you worry-free, and offered from 3-year to 5-year to 8-year, which will cover the whole lifespan of the machine, okay? And very importantly, we provide a comprehensive clinical training and clinical support, okay? And so on the clinical training side, we train the entire medical team who is going to participate in the setup of the service, which included the doctors, the specialists, the anesthesiologist, okay, and also the nurse, okay. And so the clinical training will be breaking into the on-site training, the coming to China if without the COVID-19. Now we added online training component to cut down the training time, okay? Because we know the doctor's time, specialist time from any country, whether it's from public service or private service, all precious, okay? So we'll bring, actually, we already launched the 10 lectures, okay, training course as the theoretical and the step 1 clinical training program online under the ISMIF, okay, International Society of Minimal Invasive Surgery, okay. And so we'll add more and more online component utilizing our telemedicine platform, okay. And so this is, without the COVID-19, the doctor will, a team will come over to China to receive 1 month of clinical training, okay? Why? Because we have more cases here, okay? So we'll train the doctors in our national centers, well-established national centers, okay? Then once the service is set up, okay, and Raymond can attest to that, okay? And I think in South African Center, you received 6 months of clinical support with one of our experienced senior doctors who will be on site to work with you to start the service and also provide a continuous clinical training on site on your patients, okay? And also in any real clinical situation, okay? You can not only just accept the patients with 5 to 7, according to your learning curve, okay? So the patients will come, you have to deliver the service. So by providing the on-site clinical support and the training, will be able to when you during the process when you set up the service, we can also take the harder case, difficult cases more than the skills of your doctor's team, okay? And with international doctors, we also break down, depending on the experience of the doctor and the time they allowed for to be released from their duty, we can always break down, we can also break down the 1 month training coming to China into 2 parts or 3 parts, okay? So it's flexible, we do tailored, so it's tailored. So this is the comprehensive service we provide to ensure that the service can be set up properly and safely. Okay, so therefore, and also this is the first thing. So the price of will reflect the extensiveness of this total service. And second is that depending on the models, whether it's set up in the public, whether you receive the support from the government or from the Chinese government, such as the South Africa, it is the sort of, the project is set up by the support from the MOST, okay, Ministry of Science and Technology at the time. So we will recover we will charge for the service, but the modality was sort of given in free, okay, and to the hospital, okay, and so it depends on the situation, how the service is set up, okay, and it can, so we have, that comes down to the business models, okay, so I don't have a one answer to that question. So when we move on to the project, we'll also have the feasibility assessment, okay, and the financial, the ROI calculations, and we have to work with the management team of a hospital or the doctor who want to set up the service to make sure it will work, okay. Both so the ROI will work out to reflect, to meet your needs. Okay.
Thank you, Prof, for that elaborate response. Thank you very much.
You're welcome. Okay. So do I see any other doctors who are waiting to ask the questions? Hold on, let me manage my team. I don't see any hands raising up right now. Okay, so are there any questions from the participants? If I don't see you, just just open your microphone and ask.
Professor Rosie,
Yes.
My name is Gertrude Chuma from Zambia. Yes, Dr. Muzaza, I think in his introduction,
yes.
did mention. Yes. Thank you so much for the excellent sharing. Yeah, you have taken us through very, very well. And I also recognize the presence of Dr. Muzaza and also our director, Dr. Mwiche, and all the senior colleagues who are here. Thank you so much to the presenters. That was very, very interesting presentations. Yeah, I wanted to comment on the issue of maintenance, but I thank you, Prof, that you have mentioned that there is a comprehensive package already for maintenance, which would run for a number of years, and that is very, very good. So the other question, I have a lot of questions, but because of time, I'm not able to ask them. But one that I would want to ask is, does this package, when we purchase this machine, does it come with the MRI and ultrasounds, or those have to be purchased differently? Because I think that has now extra cost implications. And the other one, like I said, I have too many questions, so I'm not going to even venture on asking them. But I would like to maybe just ask Dr. Muzaza, in also thanking him, just to mention that we have associations. We have associations that would relate very well with what is going on. There's the Surgical Society of Zambia, and also on the OBGY side, we have the Zambia Association of Obstetricians and Gynecologists. And I'm here actually representing that association as Secretary General. So I'm benefiting a lot of, concerning this discussion, because I think if I am correct, I am probably the only one from the association who is on the forum. And so in our next meeting, then we would be able to discuss some of these issues. And that is why I had a lot of questions. So that as we discuss, we understand fully what this, which is being brought to Zambia, will bring to the people of Zambia. So I saw on the forum, I think there was a comment about how if we have questions, we will be contacted. So I would appreciate that contact, so that as an association, then we are able to ask as many questions as we can. I submit. Thank you so much, Prof. Rosie. Thank you.
You're welcome, Dr. Chuma. Okay, I'll be glad to answer your question. Just, I think after this conference, because we have the 1 week long discussion with Dr. Muzaza, okay, in terms of Zambia, I think he has a pretty good idea how to bring this. Okay, our discussion is extensive, and it covers education, medical training, residence training, and also the collaboration at the society level, which that's what we do, okay? Just to give you an example, we have already formed a broad strategic partnership between the minimal invasive society of the International Society of Minimal and Non-Invasive Medicine with the major OB/GYN societies on the MIS, minimal invasive surgery side, such as the ESG, okay, such as APAGE, the European Endoscopic Society of OB/GYN, okay, and also RCOG. We just, if it's not the, we made already many visits with RCOG. If it's not the COVID-19, 2020, we already formed this a formal collaboration with the RCOG on evaluating this technology and on academic education and promotion of this technology, okay? On the French and the French-speaking side, we also formed the academic alliance, okay? And just as you said, okay, and also, so benefits to this, last year, we did 29 online conferences by working with professional organizations this can be discussed in the light of practice, medical practice, in the light of how do we bring this service, this technology into the current medical service. Okay, so yes, definitely, we have already discussed with Dr. Muzaza on form the collaboration with the Surgical Society and the OB/GYN Society, so that we can do the conference, okay, initiated by these societies. Actually, Dr. Raymond and Dr. Ajayi have been doing that, okay, in South Africa and also in Nigeria. In fact, I think Dr. Ajayi has already done 3 or 4 such conferences, okay, which is the collaboration between the ISMIF and also the Nigerian OB/GYN societies, okay? So definitely we are going to work with the local organizations, professional organizations because we believe the changing the mind of the doctors, okay, recognize this technology, need the guidance of the professional societies they trust, okay? And so yes, so this area we definitely will do, and we're looking forward to work with Dr. Muzaza, you and also your colleagues who are on the professional society side so that we can educate the doctors in the proper way, deliver the message, the right message, okay? And I'll add another word to the maintenance program, okay? Because we also, with the telemedicine platform, any machine we shipped out, okay, national, internationally, are connected to our telemedicine center 24-hour day, 7 days a week. Okay, so that means remotely we're checking your machine all the time. So we'll be able to inform you any problems if it occur, we detect it on our side. Okay, and the training program, it's not just training the doctors. We're also going to train one local engineer to do the routine maintenance. Okay, and as for the comprehensive program, our engineer will come to your site twice a year to do the full system checkup. So every 6 months, of course, we are owning many centers. This checkup time is up because of the COVID-19, because of the travel restrictions, okay? We've not been able to do that, but we move that out to the online platform. So I'm happy to say that, you know, during the COVID-19, we're still able to support on the post-maintenance side, do the post-maintenance service through the online platforms, okay? And to ensure the service can be uninterrupted, okay? So I hope that I have answered your question, Dr. Shua.
Yes, certainly you have. Thank you so much. Thank you, Prof.
Yeah, you're welcome. And I think, you know, I with the organizing committee of this webinar, and probably we'll create we have everyone left their emails, okay? So we'll create an email list of the doctors who participated in this, and we'll collect all the comments, okay? And we'll answer them each questions, and then we'll probably circulate this to the email list, so everyone who participated in this webinar can also know, have this information available to them. Therefore, we also created the the link. So for our next Zoom meetings and things, so for those who are interested, we can have a continued discussion. So I want to say that this is just the beginning, okay? I think in Africa, because the relationship between China, special relationship between China and Africa, okay? Long friendship between the two, between China and Africa, and also the unique, the common challenges that, especially in women's health, this uterine fibroids presents to the as a women's health challenge. Okay, and I think we need more than just on the clinical side. We need the government support. We need the Chinese government support. We need the professional societies, the guidance, and we need the doctors, okay, and the hospitals. We need all these resources to join together so that we can bring this technology in the accelerated speed, but in the, not for commercial reasons, but to deliver the service to the needy people, okay, so that more people can benefit from this technology, okay? And from the 3 centers we set up, okay, our belief is medicine comes with the medical culture. And Dr. Muzaza and I, we have been talking about this. This theme is recurring during our discussion this week, okay? Therefore, it is in our belief, we have to turn this technology to the doctors of that particular country, of that region, because only they know in which way that the medical culture, the particular medical culture, in that medical culture, can this technology be properly introduced and be delivered to serve the needs of the patients. So therefore, we are also very interested in form partnership with the local health organization, the professional organizations down the road to do training together. Okay, so to summarize my comments, I think, and Raymond can attest to that, and Dr. Ajayi can attest to that. Okay, after the machine is installed, that's just the beginning of a long partnership. Okay, and and it is really like that. Okay, so you have a continued support on Chongqing HIFU, on the technology, also on the academic platforms that we have been built, such as the ISMIFs, okay, such as other platforms, and also let the African voice to be heard on the international podium, okay, and Raymond, Dr. Ajayi and Dr. Mohamed has been doing that, okay, and I think with more centers set up, because of the fibroid, okay, it's such a high incidence in Africa. I think this will be the training ground for doctors, probably for the West. Okay, as Professor Wang, the founder of this technology, this morning told Dr. Muzaza, said, Dr. Muzaza, we should have a dream. And the dream is we've been receiving the trainings and technologies and being benefited from the technologies developed in the West and giving down to us, okay? But now it's the opportunity, shared opportunity of China and Africa to build up the training programs and train the Western doctors. So I think this is the dream we could, Raymond, this is something we can do. And Dr. Muzaza, and this is something we can do. Yeah, so I think today, we, down the road, I think we want to probably with 6 countries now, and but we'll build a platform for communication, for exchange, okay, so that, and we can have meetings regularly to discuss, and our goal is to form a framework about how do we deliver this technology, bring this technology and integrate it into the medical practice in Africa. Okay, so I think this is the ultimate goal. Okay, thank you. And any more comments from the audience? So, I just realized that this meeting has already lasted 2.5 hours. So the time seems by very fast because it's very stimulating. Okay, and but also I know it's the morning time in Africa. Okay, and so I probably will call the conclusion of this webinar. Okay, and if the desire is there, the needs is there, okay, and we'll do another one, focus probably on another specific topic that will emerge from this webinar, okay, and I will let our African doctors to return to your clinical work. So I know it's a Friday. It's usually Friday is also a busy day in clinical wise. Okay, and so thank you all, and thank you, Dr. Ajayi. We're looking forward to hear the good news from your center. Okay, of definitely the Nigeria HIFU baby, not too long down the road. Okay, and yeah. Okay, so next time, next webinar. We hope to see the treatment, the case from your center. Okay, and Raymond, thank you very much, and the best regards, to you and also to your team. Okay, and thank you all, and have a good weekend. Have a good weekend, everyone. Okay, bye. Thank you. Thank you.
Bye-bye.
Bye-bye. Thank you.
Bye, everyone, and thank you very much, Team Zambia.
Thank you very much. Thank you.
Thank you and bye.
Thank you very much.
Thank you. Bye.
Bye.
Thank you, everyone. Bye.
Bye.